Imagine a silent battle, one fought within the hearts of, well, half the world's population. Often misunderstood, misdiagnosed, or sometimes just overlooked entirely. It's a
Hmm.
cardiovascular journey, uniquely shaped by the subtle dance of hormones, the demands of daily life, and the very fabric of societal roles.
Exactly.
For women, heart health is distinct, it's complex, and tragically frequently underestimated. But what if we told you that understanding these nuances could unlock a powerful pathway to prevention and, well-being?
That's the key question, isn't it?
What if the key lies not just in traditional medicine, but in a profound shift towards a lifestyle specifically tailored for her?
Right.
Today, we're embarking on a deep dive into the intricate world of women's heart health, exploring how the 6 pillars of lifestyle medicine offer a personalized roadmap to protecting the hearts that, nurture families, build communities, and power our world. Before we really unpack this crucial topic, we want to extend a huge thank you to London Heartbeat's Z Academy UK. Their invaluable educational support made this deep dive possible. And for those of you eager to explore further, we highly recommend checking out their impressive catalog of over 150 popular courses.
That's quite a library.
It really is. You can also subscribe to their social media channels, Facebook, Instagram, and YouTube for free, regular updates, and to ensure you don't miss future amazing discussions like this one.
Good tip.
And for an even deeper dive, consider their higher-level YouTube membership. It offers early access to educational videos and even personal chats and guidance sessions.
Oh, interesting.
They are truly committed to empowering lifelong learning. Okay, let's unpack this with a crystal clear mission. Our goal today is to cut through the noise and provide you with a sharp, insightful understanding of cardiovascular health for women.
Right.
We're drawing from a cutting-edge review published just last year in the American Journal of Preventive Cardiology. It's a truly insightful piece of work, pulls together all the latest research.
Indeed. This deep dive aims to arm you with knowledge that goes beyond, just general health advice. We're providing a nuanced perspective on how these lifestyle medicine pillars intersect with both biological sex and social gender differences.
That distinction is so important.
It is. And this understanding directly influences women's cardiovascular risk and outcomes. It's really about recognizing these distinctions to empower earlier prevention, foster more accurate discussions with your healthcare providers, and ultimately lead to better health outcomes throughout a woman's entire lifespan.
Let me tell you about Sarah. For years, she experienced, intermittent fatigue, some shortness of breath when climbing stairs, occasional feelings of anxiety.
Common symptoms, unfortunately, often dismissed.
Exactly. Her doctors often attributed these to stress or simply being a busy mom. It wasn't until a sharp, unexplained chest pain sent her to the emergency room that a specialist, thankfully, looked beyond the typical symptoms.
Good thing she got there.
They uncovered microvascular dysfunction, a problem with the tiny blood vessels in her heart that's actually more common in women, which had been silently progressing, masked by symptoms often dismissed. Her journey highlights a crucial point we're exploring today. Women's heart disease doesn't always look like the Hollywood heart attack.
Not at all. Sarah's story really illustrates a critical gap. The lack of awareness regarding how cardiovascular disease often presents differently in women. Recognizing these nuances, moving beyond the classic clutching your chest and falling over scenario, is paramount for early detection and intervention.
Absolutely paramount.
This is precisely why a tailored understanding of lifestyle medicine, one that thoughtfully accounts for both biological sex and social gender, is not just beneficial, but truly life-saving. 2-second quiet pause.
1. Introduction. The foundational role of lifestyle medicine in women's heart health. Okay, so our understanding of heart health isn't static, right? It's constantly evolving, which is, frankly, great news for all of us. Back in 2010, the American Heart Association really shifted the conversation. They moved beyond just disease management, focusing on what they called cardiovascular health, with Life's Simple 7.
That was a big shift.
Huge! This wasn't just about treating heart attacks. It was about preventing them by tackling unhealthy lifestyle factors, things like smoking, being overweight, not enough physical activity, poor diet.
The usual suspects, but framed proactively.
Exactly. They also wisely included optimal cholesterol, blood pressure, and blood sugar levels as part of these overall health goals. It provided a clear blueprint for proactive health.
And that same pivotal year, 2010, saw the emergence of the American College of Lifestyle Medicine, or ACLM. They published their own position, outlining the core clinical competencies for physicians.
So parallel development.
Yes, a monumental step towards formally integrating lifestyle interventions. things like diet and exercise directly into patient care to optimize outcomes for chronic diseases.
Uh,
This foundation paved the way for board certification in lifestyle medicine, emphasizing the credibility and the evidence-based nature of these approaches.
yeah.
It truly signaled a growing recognition of the profound power of daily habits to shape our health.
Okay, fast forward to 2022. The AHA updated their framework again to Life's Essential 8.
Essentially, right.
What's truly fascinating here is the addition of sleep as a core healthy lifestyle habit. That's new, alongside diet, physical activity, and avoiding nicotine.
Sleep finally getting its due.
Totally. They also refined how they assess these metrics and, importantly, recognize the foundational role of psychological health, overall well-being, and even the social factors around us, often called social determinants of health.
Yeah.
This wasn't just a tweak, it was a profound acknowledgement of the interconnectedness of our entire lives with our heart health.
Absolutely. The ACLM also updated its core competencies in 2022, echoing this broader perspective. This wasn't just about new medical knowledge, it highlighted the importance of what they call the therapeutic alliance.
The patient-doctor relationship.
Exactly, that collaborative, trusting relationship between you and your clinician.
Yeah.
They emphasize using open inquiry, reflection, and empathy as fundamental tools for behavior change.
Makes sense.
And, significantly, they acknowledge that lifestyle medicine's principles also support clinician well-being, addressing things like practitioner resilience and burnout.
That's interesting. So it benefits everyone.
It does. It tells us that even your doctor's ability to help you can be linked to these principles, showing how truly holistic this approach is to health, extending beyond just the individual patient to the entire ecosystem of care.
So if you consult an LM-certified clinician, they're trained to work with you using evidence-based whole-person recommendations based on what we call the 6 pillars of lifestyle medicine. What are these foundational pillars?
Okay, so the 6 pillars are physical activity, a whole food plant predominant eating pattern, restorative sleep, stress management, positive social connections, and avoidance of risky substances like tobacco and excessive alcohol.
You can immediately see the significant overlap with the AHA's Life's Essential 8.
Huge overlap.
This alignment is crucial because it positions lifestyle medicine and cardiology as, well, natural partners in the fight against cardiovascular disease.
They really complement each other.
Right. While cardiologists have their tools, medications, procedures, lifestyle medicine offers complementary strategies focused on prevention and management through our daily habits.
Exactly. This partnership means a more comprehensive approach to your heart health, where medical treatment and lifestyle changes work hand in hand, creating a much more robust shield against disease.
Okay, here's where it gets really interesting and often misunderstood. Our sources emphasize that both sex and gender can profoundly influence lifestyle factors and lead to different effects on cardiovascular risk. What's the difference between these two terms? Why is this distinction so critical for understanding women's heart health?
It's vital to distinguish between them because they both play powerful, distinct roles. Sex refers to biological variables rooted in anatomy, physiology, genetics, hormones. It's about the biological hardware, so to speak, you're born with.
Okay, biological.
Gender, on the other hand, is a social and cultural variable. It encompasses your identity, how you express yourself, and the societal expectations placed upon us all.
Social construct. Got it.
This distinction is crucial because both biological and social factors uniquely shape a woman's health journey. We also need to recognize intersectionality, how sex and gender intertwine with factors like race, ethnicity, where you live, your education, your income.
Right, all those overlapping factors.
Exactly. These broader social and environmental determinants significantly shape health outcomes, creating layers of complexity in how health is experienced and maintained. For our deep dive today, the research primarily focuses on female as a biological sex and women when discussing gender or combined factors.
So for females and women, what are some of these specific biological or social factors that impact cardiovascular disease risk and how we approach these lifestyle medicine pillars?
It sounds like it's much more than just the obvious things. Absolutely, it's a very nuanced picture. First, consider the profound impact of hormonal fluctuations. Throughout the menstrual cycle, pregnancy, the postpartum period, and especially during menopause, a woman's fluctuating hormone levels directly impact her vascular health and how her body processes sugar and insulin.
Wow, through her whole life, basically.
Exactly. This isn't just about reproduction. It's a powerful biological driver of cardiovascular health changes throughout her life. Then there are immune system differences. Females tend to have higher rates of autoimmune disorders and often have greater baseline inflammation.
Inflammation again.
Yes. Their immune responses are also more pronounced in the presence of traditional risk factors like diabetes or high blood pressure, and even non-traditional ones like critical illness.
Which leads to...
A critical point. Traditional heart disease risk scores can actually underestimate risk in individuals with these immune system differences.
Oh, that's worrying.
It is. The good news, though, is that lifestyle choices aimed at reducing inflammation appear to be significantly more impactful for females, meaning a healthy lifestyle can have an even stronger protective effect.
Okay, that's empowering.
And lastly, we cannot ignore societal roles and disparities. Women are statistically more likely to be primary caregivers for children and aging parents. They face higher rates of intimate partner violence and are disproportionately affected by poverty.
Real-world challenges.
All of these factors directly impact their access to, engagement with, and ability to stick with lifestyle medicine recommendations, making healthy changes just plain harder to implement and sustain sometimes.
This all paints a picture of a truly unique journey for women's heart health. But the flip side is that it also presents crucial opportunities, doesn't it? These distinct phases of a woman's life seem like key moments where we can step in and make a real difference.
Absolutely. Recognizing conditions like polycystic ovarian syndrome, PCOS, gestational diabetes, hypertensive disorders of pregnancy, like preeclampsia, early menopause, and the severity of hot flashes, or what we call vasomotor symptoms, VMS. These aren't just isolated health events.
They're signals.
They are crucial predictors of higher cardiovascular and cardiometabolic risks later in life. This knowledge provides a strategic advantage. These stages, reproductive age and perimenopause, become prime windows of opportunity to discuss and implement lifestyle modifications.
So intervening earlier.
Exactly. Earlier education on how lifestyle can support fertility, healthy pregnancies, manage menopausal symptoms, and simultaneously improve cardiovascular health. This understanding also supports earlier discussions and referrals when indicated to specialists like preventive cardiologists and a whole team of LM-certified clinicians, physicians, dietitians, exercise physiologists, sleep specialists, social workers, behavioral therapists, coaches.
A whole team approach.
Yes. The goal is to align lifestyle medicine education with women's specific symptoms, preferences, and goals. This customized approach is key to increasing adherence to guidelines around physical activity, whole food plant-predominant nutrition, sleep quality, stress management, social connections, and avoiding risky substances, ultimately reducing cardiovascular risk.
Okay, time for our first question to get you thinking. To kick us off, which of the following was not explicitly added to the American Heart Association's Life's Essential 8 in 2022 compared to Life's Simple 7? A, sleep. B, psychological health well-being. C, social determinants of health. D, optimal cholesterol levels. And question 2. When discussing women's heart health, sex primarily refers to A, social and cultural expectations. B, gender identity and expression. C, biological variables like anatomy, physiology, and hormones. D, the influence of community and environment. 2-second quiet pause. 2, nutrition, the fuel for a healthy heart women's unique dietary landscape. All right, moving on to our next pillar, nutrition. Our sources highlight that this is the lifestyle medicine pillar most strongly associated with cardiovascular risk and cardiometabolic health. Huge impact.
Undeniably.
Yet, here's a sobering fact. Fewer than 1% of the entire population actually meets recommendations for a healthy dietary pattern.
It's a staggering statistic.
This is a critical disconnect, isn't it? We know nutrition is vital, but so few are getting it right.
Indeed. And the evidence is just overwhelming. Major studies, like PREDIMUDE and the Diabetes Prevention Program, have consistently demonstrated that healthy dietary patterns can significantly reduce cardiovascular events, cardiac risk factors, and the incidence of diabetes. These are not minor effects, they are profound, showing that simply changing what you eat can have a powerful, life-altering impact on your heart and metabolic health. Now, when we look at dietary intake through the lens of sex and gender, a fascinating and complex picture emerges. For instance, early research suggested women were less likely to meet recommendations for both macro and micronutrients and more likely to be obese.
Okay.
However, what's truly insightful here is that these differences largely disappeared when adjusted for factors like poverty and other socioeconomic indicators.
So it's not biology, it's circumstances.
It strongly suggests that food insecurity disproportionately affects women, impacting their ability to achieve optimal nutrition rather than an inherent biological difference in dietary choices.
That makes sense.
Delving deeper, women may also experience a higher emotional susceptibility to disinhibition around food intake.
Meaning stress eating.
Basically, yes. Stress can have a stronger, more negative association with both the quality and quantity of their diet, particularly for those with lower socioeconomic status. And motherhood itself is a factor. Studies found mothers of toddlers and older children tended to have less healthy diets compared to women who hadn't had children, possibly due to time constraints, stress, demands of caregiving.
The juggle is real.
It is. Furthermore, research from large population databases indicated women were more likely to consume too much sugar, total fat, and saturated fat compared to men, while most men and women both fell short on fiber, highlighting specific areas for targeted dietary intervention.
So how do these dietary differences actually translate into cardiovascular risk factors? What's the practical impact on a woman's heart and overall cardiometabolic health?
They translate quite directly into specific risk factor profiles. For example, when looking at high blood pressure, females showed a more consistent, linear link between adhering to a healthy eating index and lower risk.
So for women, better diet, lower risk, pretty clear cut.
More or less, yes. Males, interestingly, showed a more complex U-shaped relationship, implying both very low and very high adherence might have different effects, suggests a different physiological response.
Interesting.
Regarding visceral adipose tissue, that dangerous fat around organs healthy eating had a greater impact on reducing this type of fat in females, especially younger, Caucasian women, and those with existing obesity and diabetes.
So a more potent effect for those groups.
Seems so. In terms of overall cardiometabolic disease risk, one study found a stronger association in females between high dairy intake and lower intake of fruit, plant protein, and seafood with a higher prevalence of risk factors. Low intake of vegetables, however, was a risk factor for both sexes, showing some universal nutritional needs.
Right. Veggies are good for everyone.
Pretty much. And let's not forget the powerful hormonal influence we mentioned. Women's fluctuating nutritional needs throughout their reproductive years directly impact menstrual cycles, fertility, pregnancy outcomes, perimenopausal symptoms. Conditions like PCOS, gestational diabetes, hypertensive disorders of pregnancy are all linked to higher immediate and future risk of hypertension, diabetes, and CVD. Underscores how deeply intertwined nutrition and hormones are for women's heart health.
Pregnancy is such a transformative time, and it's clearly also a crucial window for heart health, isn't it? It seems like a period where dietary choices can have magnified effects for both mother and baby.
Absolutely. Being overweight or obese before pregnancy is strongly linked to a significantly increased risk of hypertensive disorders of pregnancy. The risk is more than double for mothers who are overweight, more than triple for those who are obese. And this isn't just about weight. Specific dietary patterns play a huge role. Women whose diets were high in processed meat, salty snacks, sugary drinks faced a higher risk. Conversely, those with higher intake of vegetables, plant foods, vegetable oils were at significantly lower risk.
So eat your veggies, basically.
Especially during pregnancy, yes. Fiber's power is particularly notable here. For example, women who consumed the most dietary fiber, over about 21 grams per day, had a remarkably reduced risk of preeclampsia.
That's a huge reduction.
It is. This higher fiber intake was also associated with lower triglycerides and higher levels of beneficial HDL cholesterol. Really underscores the protective effect of a plant-rich, high-fiber diet during this critical phase.
But what drives women's food choices during pregnancy? Are they always prioritizing the healthiest options, or are there other factors at play, like cravings?
Women often make dietary changes with the best intentions, which presents a fantastic opportunity, actually.
How so?
Well, they cited promoting their baby's health as a key reason for reducing things like alcohol, caffeine, raw fish. Makes sense. However, the most common reason for increasing certain foods was often due to cravings, often for sweets and fruit, rather than specifically prioritizing foods rich in essential nutrients for pregnancy, like folate or iron-rich vegetables.
Ah, the craving trap.
Exactly. But this presents a clear opportunity for healthcare providers. We can match nutrition education about increasing vegetables, plant foods, and fiber to a woman's existing powerful goal of promoting her baby's health. Make the healthy choice more intuitive and motivating.
Now, as women transition through menopause, there are those profound hormonal shifts. How does this impact heart health and nutrition? It feels like another critical window of opportunity that maybe often gets missed.
It is indeed a pivotal phase. Declining estrogen and progesterone levels during menopause are significant. They contribute to a reduced basal metabolic rate, loss of muscle mass, reduced insulin sensitivity.
So metabolism slows, body composition changes.
Right. A shift towards more fat accumulation around the middle, unfavorable changes in cholesterol, more bad LDL, less good HDL, issues with blood vessel function, increased inflammation. All of these factors converge to significantly increase cardiometabolic risk.
So what helps counteract that?
Higher protein intake becomes crucial here, potentially helping to reduce muscle loss and maintain physical function post-menopause. Studies, like the long-running Nurses' Health Study, have shown that higher plant protein intake compared to animal protein is associated with healthy aging, lower chronic disease risk, better physical and mental status.
Plant protein for the win.
It looks promising. Targeted diets also show promise. One study in postmenopausal women with hot flashes found a low-fat vegan diet, including half a cup of cooked soybeans daily, significantly reduced the frequency and severity of these symptoms.
Soy for hot flashes. Interesting.
And another pilot study on overweight women with hot flashes showed a behavioral weight loss intervention led to more weight loss and symptom reduction, with women finding symptom alleviation a strong motivator for sticking with it.
Beyond individual choices, what about broader societal factors influencing nutrition? Are there systemic issues at play that make healthy eating harder for some women than others?
Absolutely. A significant review in 2020 powerfully identified targeted food marketing, structural racism, neighborhood segregation, unhealthy built environments like a lack of grocery stores or safe places to walk, and food insecurity as major contributors to disparities in dietary quality and cardiovascular risk, especially by race, ethnicity, and socioeconomic status.
Systemic barriers.
Yes. The call here is for public policy changes to improve the affordability and accessibility of healthy foods. The recent changes in the WIC Women, Infants, and Children federal program are a great example of positive policy.
What did they change?
They significantly increased vouchers for fruits and vegetables, expanded access to whole grains, and reduced allowances for fruit juice and milk. These changes directly impact low-income mothers and children, demonstrating how policy can create real, positive change on a large scale.
Okay, next question for you. According to the source material, when do women show a stronger negative association between stress and diet quality and quantity? A, only in high-income settings. B, in women with lower socioeconomic status. C, universally, regardless of socioeconomic status. D, only during pregnancy. And number 4, what was a significant finding regarding dietary fiber intake and preeclampsia risk during pregnancy? A, higher fiber intake had no effect on preeclampsia risk. B, women with the lowest fiber intake had the lowest preeclampsia risk. C, the highest quartile of fiber intake was associated with a significantly reduced risk of preeclampsia. D, fiber intake only affected triglyceride levels, not preeclampsia. 2-second quiet pause. 3, physical activity, the body's best defense, surprising benefits for women. Physical activity. We all know it's good for us, but the depth of its impact on cardiovascular health is truly profound, isn't it?
Absolutely essential.
Our sources confirm it's consistently associated with reduced cardiovascular disease, cardiovascular mortality, and all-cause mortality. It's not just about one thing either. Physical activity has a multi-system impact on health, meaning even small improvements across various risk factors, lipids, weight, blood pressure, blood sugar, add up to a significant overall benefit.
Right, the cumulative effect is powerful.
What's particularly fascinating, though, is that studies like the Women's Health Study showed that the impact of physical activity on known cardiovascular risk factors only explains about 60% of the observed risk reduction in females.
60%, so there's more going on.
Exactly. It suggests there are still many, maybe mysterious, powerful mechanisms we don't fully understand about how movement improves cardiovascular health, particularly in women.
The general guidelines for physical activity don't actually differ based on sex, which is important to note. We're generally looking at 150-300 minutes per week of moderate intensity activity. Think brisk walking, dancing.
Getting your heart rate up a bit.
Right, or 75-150 minutes of vigorous intensity aerobic activity, like running or swimming laps, plus 2 sessions per week of muscle strengthening activity.
So cardio and strength.
Exactly. These are universal recommendations designed to provide a broad range of health benefits for everyone.
Despite these clear benefits, there's a significant disparity that needs our attention. Women are generally less active than men, from late childhood right through adulthood.
That gap persists, unfortunately.
Yeah. In the U.S., only about 20% of women meet the minimal recommended physical activity levels, compared to 28% of adult men. That's a considerable gap, and it means many women are missing out on these profound health advantages.
But it's really important to remember that some physical activity is better than none.
Every little bit counts.
It really does. Even if you're below the recommended levels, any physical activity significantly lowers mortality compared to being fully sedentary. Those who do meet the guideline recommended minimums, especially when measured by activity trackers rather than just self-report.
More objective measures.
Right. They can achieve 30% to 60% lower mortality. Beyond these minimums, while more activity is generally good, the dose-response curve shows diminishing returns. It plateaus around 3 to 5 times the minimum recommended levels.
So you don't have to be an ultramarathoner.
Not at all. This makes the guideline levels a real sweet spot. Most of the benefits are achieved, and they're attainable for most adults.
But here's where it gets really interesting, and I think our listeners will find this truly empowering. Several studies suggest that at any given dose of physical activity, females may derive more benefit on outcomes.
That's the kicker, isn't it?
It's a game changer. What does this mean in practical terms for women who are trying to stay active? More bang for their buck.
Essentially, yes. This is a truly significant finding, suggesting a greater return on investment for women's efforts. For aerobic activity, a large meta-analysis found that while both sexes benefited, women saw a statistically greater reduction in all-cause mortality. Another large study focusing on coronary heart disease showed even more profound differences. Women reporting around 300 minutes per week of moderate activity had 28% lower risk of coronary heart disease compared to only 18% in men.
10% difference, that's substantial.
It is. And this pattern holds even more strongly for muscle strengthening. While the data for strength training isn't quite as extensive as for aerobic activity, recent studies show about a 15% lower mortality for those doing any strength work.
Just doing something helps?
Yes. There's also a sweet spot for strength training, with the most benefit coming from more modest amounts, like maybe 50 minutes per week or 2-3 sessions. But crucially, females appear to derive greater benefit from any given amount of muscle strengthening activity.
How much greater?
Those completing 2-3 sessions per week saw a 26% reduction in mortality, almost double the 14% reduction seen in males for the same dose.
Double. Okay, that is a powerful message for women to embrace strength training. Your efforts are truly amplified.
The reasons for these observed sex-based differences in participation and impact are complex and honestly not fully understood. They likely include fundamental differences in exercise physiology. The biological machinery of a female body can simply respond differently to exercise.
Makes sense.
Life events like pregnancy and childbearing also play a significant role, impacting activity levels and body changes that can be long-lasting. And broader societal factors influencing access to sports participation. Safe places to be active can further reduce women's physical activity levels throughout life.
Barriers again.
Yes. This affects their baseline cardiorespiratory fitness and muscular strength, and even the types of activities they choose. These combined factors can influence how physical activity is self-reported and how these dose-response relationships manifest in real-world outcomes.
So the takeaway here is crystal clear. Physical activity is an incredibly powerful tool to improve cardiovascular disease risk and longevity. And for females and women, it's potentially even more impactful as they appear to derive greater benefit, despite being less likely to meet recommended levels. This is truly a call to action for every woman listening.
This emphasizes a consistent message for everyone listening. Some physical activity is always better than none. And if you can work towards those guideline-recommended levels, you are truly optimizing your cardiovascular health in a way that is incredibly potent, especially for women. Every bit counts. And for women, it often counts for even more in terms of heart protection.
All right, question 5. For women, physical activity's impact on known cardiovascular risk factors explains approximately what percentage of the observed CVD risk reduction: A, 90%, B, 75%, C, 60%, D, 40%. And number 6, compared to men, what is a key finding about the benefits women derive from muscle strengthening activity at a given dose? A, women derive less benefit. B, women derive about the same benefit. C, women derive almost double the benefit. D, muscle strengthening only benefits men for mortality reduction. 2-second quiet pause. Let's consider another example, Maria. In her early 40s, feeling sluggish, she decided, okay, time for a change. Started brisk walking 30 minutes, 5 times a week, and added 2 short bodyweight strength training sessions. Nothing crazy.
That sounds achievable.
Right. Her initial goal was just to lose a few pounds, but after 6 months, not only did she feel more energetic, her blood pressure, which had been creeping up, significantly improved. Her cholesterol numbers looked better than they had in years.
Great result.
And her doctor was particularly impressed, noting that the extent of her cardiovascular improvement was often more pronounced than they'd see in men with similar activity levels, aligning perfectly with what we just discussed about women deriving greater benefit.
Maria's experience beautifully illustrates the amplified cardiovascular benefits women can gain from consistent physical activity, even at those guideline-recommended levels. This enhanced response can serve as a powerful motivator, knowing that for women, every step and every lift can translate into a significantly greater return on investment for their heart health compared to, general population averages. It's a clear demonstration of how simple, consistent efforts can yield disproportionately positive results for women. 2-second quiet pause.
4. Sleep. The silent guardian of heart health women's unique sleep challenges. Sleep, oh boy, often the first thing to get sacrificed in our busy lives, right?
Sadly, yes.
But the recognition of sleep's profound role in women's cardiovascular health has grown significantly in recent years. It's not just about feeling tired. Both the duration and the quality of sleep have a massive impact on a wide variety of heart conditions.
It's fundamental.
What's even more striking is how women's sleep patterns are disproportionately impacted by their roles. Caring for elderly parents, attending to newborns postpartum, shift work, and yes, even by their snoring male partners.
That one resonates with many, I'm sure.
Right. These are unique burdens that directly affect sleep, making it a critical area to address for women.
This is a critical area where sex and gender differences become particularly clear and often lead to underdiagnosis, which is a real problem. Let's look at obstructive sleep apnea, OSA, where breathing repeatedly stops and starts during sleep.
Scary stuff.
It is. And while it's more prevalent in men, OSA is often underdiagnosed in women. Standard screening questionnaires are actually less sensitive in women, meaning many cases just get missed.
Why is that?
Well, women are also more likely to deny or underestimate their snoring, which can lead both patients and clinicians to overlook sleep-disordered breathing. Plus, females with OSA are less likely than men to present with classic symptoms like nocturnal gasping or choking.
So what do they present with?
More often, daytime symptoms like fatigue, depression, fibromyalgia symptoms that can easily be misattributed to other causes, delaying diagnosis and much-needed treatment. Then there's something called upper airway resistance syndrome, or URS. It's actually a more common type of sleep-disordered breathing in females than males, especially at lower body weights.
URS. Haven't heard as much about that one.
Right. Imagine your airway getting slightly narrower when you sleep, making it harder to breathe, causing frequent tiny awakenings throughout the night without actually stopping breathing or significantly dropping oxygen levels like in classic OSA.
So more subtle.
More subtle, yes. Women with URs commonly present with insomnia symptoms, alongside a higher prevalence of muscle pain, fatigue, depression, reduced quality of life. The diagnosis is challenging because it involves increased resistance in the upper airway with brainwave evidence of awakenings, but often without those significant oxygen drops.
So standard tests might miss it?
It can often be missed or significantly underestimated by standard home sleep studies, again highlighting a diagnostic blind spot for women. And finally, restless leg syndrome, RLS. That condition with the irresistible urge to move the legs, right? It significantly reduces sleep quality and is more prevalent in females.
I know people who suffer terribly with that.
It's rough, and its prevalence dramatically rises during pregnancy, particularly in the second and third trimesters.
Yeah.
This isn't just a comfort issue either. RLS is associated with substantial cardiac risk.
Really? Heart risk from RLS?
Yes. Women with RLS for over 3 years had a significantly higher risk of non-fatal heart attack and fatal coronary heart disease compared to women without RLS.
That's alarming.
It is. And alarmingly, RLS is not routinely screened for in pregnancy or at other points in women's healthcare, representing a major missed opportunity for prevention. The good news is that improvements in iron and folate intake through diet or supplements have shown promise in reversing this syndrome.
It really seems that sleep is just deeply intertwined with a woman's hormonal journey. These aren't just isolated issues, but part of a larger interconnected system that can significantly impact her heart health over time.
You've hit on a crucial point. Let's explore some key periods. Hypertensive disorders of pregnancy, HDP, including severe conditions like preeclampsia, high blood pressure in pregnancy, affect over 1 in 7 hospital deliveries.
1 in 7, that's high.
It is, and preeclampsia dramatically increases future risk. A 4-fold increase in heart failure risk, a 2-fold increased risk in coronary heart disease, stroke, and death later in life.
Wow, long-term consequences.
Significant ones.
Yeah.
Critically, preeclampsia is highly correlated with sleep-disordered breathing, including both OSA and URs. The presence of sleep-disordered breathing in women in their 3rd trimester is associated with an astounding 8-fold increased likelihood of preeclampsia.
Like times.
Huge! A randomized controlled trial using CPAP continuous positive airway pressure for OSA in pregnant women showed significant lowering of blood pressure and halved the incidence of preeclampsia, demonstrates a clear intervention pathway. Next, consider polycystic ovarian syndrome, PCOS, common hormonal disorder in reproductive age females, leading cause of infertility. Patients with PCOS have a more than six-fold increased incidence of sleep disturbances, including sleep-disordered breathing.
Sixfold. Another big jump.
Yes. These patients also carry multiple elevated risk factors for cardiovascular disease, high blood pressure, elevated blood sugar, unhealthy cholesterol, higher BMI, along with substantially elevated risks of heart attack, ischemic heart disease, and stroke. The presence of OSA, specifically in women with PCOS, is associated with a worsening of these cardiovascular risk factors, creating a complex web of interconnected health challenges. And finally, the menopause transition. This period is associated with a significant increase in sleep disturbances. 56% of women report poor quality sleep and nighttime awakening, compared to about 31% in premenopausal women.
That's a big jump, too. What drives it?
Lower estrogen levels, higher follicle-stimulating hormone, and the frequency and severity of hot flashes are all directly linked to more sleep disturbances. The prevalence of sleep-disordered breathing also increases during menopause, even independent of weight and age. And hot flashes themselves are associated with higher sleep apnea risk scores and overall cardiovascular risk, suggesting shared underlying mechanisms between hormonal shifts, sleep quality, and heart health.
So, what are the solutions for these widespread sleep issues? Are there effective interventions that address these unique challenges for women, particularly since, as you said, they're often overlooked?
Well, while prescription sleep aids are often used, they can carry their own cardiovascular risks. And notably, women are more likely than men to use these aids, with use doubling in the U.S. in just a decade.
Howling. Wow.
However, the American College of Physicians recommends cognitive behavioral therapy for insomnia, or CBTI, as the first-line therapy.
Therapy, not pills first.
Right. CBTI has shown great efficacy in improving sleep quality in pregnant women, and also for both sleep quality and hot flashes in women during the menopausal transition and postmenopause.
That's great news.
It is. Despite how common disturbed sleep is for women, it's rarely discussed and often accepted as culturally normal, which represents a significant cultural blind spot that needs to change.
Just part of being a woman.
Exactly. That needs to stop. There's an urgent need for provider education on the importance of sleep in reproductive, prenatal, and lifelong women's health outcomes. This is critical to improve screening, recognition, referral for women's sleep disorders. Societal support is also key. More flexible work schedules, shared responsibility with partners could help women manage caregiving demands without sacrificing sleep.
Systemic changes again.
Yes, these intervention window screening and earlier detection of sleep disorders like RLS and sleep-disordered breathing in women with PCOS during pregnancy, experiencing menopausal hot flashes offer crucial opportunities for cardiovascular risk assessment and interventions like CPAP, CBTI, targeted dietary and lifestyle changes. All of these improve outcomes and overall cardiovascular health.
Okay, question 7. Which sleep disorder is more common in females and sees its prevalence rise during pregnancy, particularly in the second and third trimesters? A. Obstructive sleep apnea, OSA. B. Upper airway resistance syndrome, ARS. C. Restless leg syndrome, RLS. D. Narcolepsy. And number 8. For women in the menopause transition, what is associated with increased sleep disturbances? A. Higher levels of estradiol estrogen. B. Lower follicular stimulating hormone, FSH. C. Increased frequency and severity of vasomotor symptoms, VMS, or hot flashes. D. Decreased body mass index, BMI. 2-second quiet pause. 5. Stress. The silent overload women's unique vulnerabilities and responses. Okay, stress. We all feel it, but the impact of stress on the heart, especially for women, seems to be far more significant than many realize.
It's a major player.
The landmark 52-country Interheart study found that high psychosocial stress in the previous year was associated with more than double the risk of myocardial infarction, a heart attack.
Double the risk.
Across all regions, ethnicities, sexes, even after correcting for traditional cardiac risk factors. That's a staggering finding, showing stress isn't just in your head, it's in your heart.
And it's not just about acute dramatic stress either. Acute stressful events, natural disaster, losing a job, clearly linked to increased cardiovascular events. But chronic or repeated exposures to stress, ongoing work, domestic financial pressures are associated with the acceleration of atherosclerosis, the hardening of the arteries.
A slow burn.
Exactly. Other powerful systemic contributors to chronic stress include discrimination and racism, adding layers of societal impact. The cognitive, emotional, biological responses to stress are highly individualized, influenced by genetics, past experience and memory, social support, and crucially, both biological sex and social gender factors.
So many inputs.
Yes. Chronic stress directly impacts cardiovascular risk factors like inflammation, how blood clots, insulin resistance, high blood pressure. It also has indirect effects, pushing individuals towards unhealthy behavior, substance use, poor diet quality. This chronic stress is also linked to a higher risk for depression and anxiety, with social isolation and worrying acting as mediators. It's worth noting, though, that measuring stress consistently in studies is challenging, which makes quantifying its precise impact difficult, but the overall impact is undeniable.
That's a lot of complex interactions. So, are there differences in how women experience and react to stress compared to men? It sounds like there might be.
This is a key area of difference, yes. Higher rates of perceived stress, depression, and anxiety are consistently observed in women compared to men. The American Psychological Association's 2023 Stress in America survey found women reported higher average stress levels, 5.3 versus 4.8 out of 10, and a larger percentage, 27% versus 21%, rated their stress as 8 or higher.
Feeling it more intensely.
It seems so. These higher rates of anxiety and depression in women often begin around puberty and are linked to fluctuating hormone levels. Interestingly, post-menopause, these rates tend to decline, approaching those seen in men, underscoring that hormonal shifts play a significant role.
Hormones again.
Yep. Brain imaging studies also illustrate distinct sex differences in how the brain responds to stress. In acute stress, females show more activation in emotional and attention areas. Estrogen, in particular, impacts multiple brain chemical systems and influences brain structures involved in emotional processing. And beyond biology, societal factors play a huge role. Women are more likely than men to be exposed to intimate partner violence, more likely to live in poverty, with these disparities being even greater for ethnic minorities.
Compounding factors.
Exactly. The timing of stress exposure, coupled with the prevailing hormonal environment and subsequent fluctuations, can interact to influence a woman's risk for depression, anxiety, PTSD. Social support, though, has been shown to significantly improve stress resilience and reduce the risk of anxiety and depression in stressful situations. And this benefit appears to be even more impactful for women.
So connection helps buffer stress, especially for women.
It seems to. Furthermore, women generally bear a greater share of the mental and physical labor associated with unpaid work household duties, childcare, other caregiving roles. This constant cognitive demand of unpaid labor is strongly associated with emotional stress, worse mental health, overall life dissatisfaction, creating a constant, often invisible burden.
So it's not just about feeling stressed, it's about what stress does to a woman's heart on a physiological level. These unique vulnerabilities have tangible, measurable consequences for her cardiovascular system, don't they?
Exactly. Takotsubo syndrome, often called broken heart syndrome, is a vivid example. 80–90% of cases occur in postmenopausal females.
But mostly women. Why?
Proposed mechanisms include the loss of estrogen's protective effects against stress hormones, leading to inflammation and abnormal blood vessel responses. Underlying anxiety or depression are present in as many as 30% of patients.
Wow.
In terms of inflammation, baseline levels and their subsequent rise in response to stress are higher in females with coronary artery disease than in males. For each standard deviation increase in stress-related inflammation, women faced a 56% greater risk of adverse cardiovascular events, a finding not seen in males.
A huge difference.
Stress also has a stronger impact on blood sugar regulation and unhealthy cholesterol levels in women compared to men. The Cardia study found higher chronic perceived stress was associated with greater risk of early atherosclerosis in women, but not in men.
Another sex difference.
Yes. Rates of anxiety, depression, PTSD are higher in women who survive sudden cardiac death and post-heart attack.
Right.
And finally, mental stress-induced myocardial ischemia, where the heart doesn't get enough blood flow due to mental stress. Young and middle-aged females with heart disease are twice as likely to experience this, even after adjusting for other factors.
Of course is likely.
And this is mediated by stress-induced blood vessel constriction and changes in the tiny blood vessels again, a mechanism not observed in males. Both higher psychological distress and a worse microvascular response to stress are associated with significantly higher risk for future events in women, but not for men. It clearly demonstrates the unique and profound impact of stress on the female cardiovascular system.
Given these unique impacts, are there differences in how women prefer to manage stress? Understanding this could lead to more effective, tailored interventions to support them, right?
Yes, there appear to be sex and gender differences in stress management preferences. One major survey found that while women and men equally turned to exercise and music, women were more likely than men to engage in social and sedentary activities like reading or spending time with friends and family.
Seeking connection or quiet time.
Seems so. A higher percentage of women reported using some form of meditation compared to men. Among meditators, women were more likely to combine meditation with practices like yoga or Tai Chi, while men were more likely to report specific practices like mindful meditation.
Interesting preferences.
And in terms of effectiveness, another study in women found that active meditation protocols significantly enhanced mood and activated the parasympathetic nervous system, our rest and digest system, whereas silent meditation did not show a significant increase in positive mood or consistent changes in this system.
So active meditation might be more beneficial for women's mood.
Potentially. The conclusion here is clear. The higher prevalence of anxiety, depression, perceived stress in women, both with and without heart disease, coupled with stress's more profound impact on inflammation, microvascular dysfunction, blood flow issues. It undeniably contributes to the worst clinical outcomes often observed for women presenting with acute coronary syndromes. Tailoring stress management to these preferences and physiological responses is absolutely key.
Question 9. According to the InterHeart study, high psychosocial stress in the previous year was associated with what increase in myocardial infarction risk? A, less than 1.5 times higher risk. B, approximately 1.5 times higher risk. C, more than 2 times higher risk. D, no significant increase in risk. And number 10, which of the following stress-related conditions occurs in 80–90% of cases in postmenopausal females and is linked to the loss of estrogen's protective effects? A, atherosclerosis. B, hypertension. C, Takotsubo syndrome, broken heart syndrome. D, insulin resistance. 2-second quiet pause. 6, substance use. Hidden vulnerabilities and unique risks for women. Now, let's talk about substance use, a pillar that often has significant impacts on heart health. Our sources reveal a crucial paradox here. Women are generally less likely to use tobacco and alcohol, yet they appear to be at a higher risk of adverse health consequences from that use.
Right, less use but more harm potential. It's a critical point.
It is. This is a critical area for understanding specific vulnerabilities that clinicians and individuals really need to be aware of.
Let's break this down, starting with tobacco. In the U.S., tobacco use of any sort and smoking are less common in women compared to men. However, while smoking has been declining for decades in both sexes, in some countries, this gender gap is narrowing as rates decline more slowly in females, which is concerning.
Not good.
No. Tobacco remains a leading cause of preventable diseases, coronary artery disease, stroke. But critically, female smokers are more likely to develop and die from coronary artery disease and heart attacks than male smokers.
More likely, even if they smoke less.
Yes. Similarly, they face higher risks of stroke and abdominal aortic aneurysm. This heightened susceptibility in women is thought to be related to smoking's effect on lowering cardioprotective estrogen levels in younger females and a differential impact of smoking on the blood vessels themselves.
Oh, the vascular impact again.
Exactly. What's more, cardiovascular risk in female smokers is further amplified by the use of hormonal contraception, a common factor in women's health.
The pill plus smoking is extra bad.
Significantly riskier, yes. The good news, and this is important, is that smoking cessation is associated with a dramatic reduction in cardiovascular disease risk, often returning to that of a never smoker. Highlights the profound immediate benefit of quitting. Now, for alcohol use. Excessive alcohol use is defined differently by sex. For males, it's 15 or more drinks per week. For females, it's 8 or more drinks per week, or any use by pregnant females.
Lower threshold for women.
Yes. Adult women are less likely than men to be current drinkers, binge drinkers, or to have an alcohol use disorder. However, these rates are converging over time, with younger generations showing more similar rates, and even high school-aged women sometimes having higher alcohol use than men.
That's a worrying trend.
It is. Despite consuming less, women appear to be at a higher risk of alcohol-related cardiovascular disease.
Why is that?
It's largely due to biological differences. Women typically have a smaller average body size and different alcohol metabolism, leading to higher and more sustained blood alcohol levels after a given amount of consumption.
So the same drink hits harder?
Essentially, yes. The risk of alcohol-related heart muscle disease, cardiomyopathy, occurs with fewer years of exposure and lower levels of consumption in females, even when adjusted for body weight.
Faster damage.
Seems so. Excess alcohol also increases cardiovascular risk factors like high blood pressure and diabetes, as well as heart diseases such as stroke and atrial fibrillation in females. And it's important to note a shifting scientific view. While moderate alcohol was once thought to be potentially health-promoting for heart disease.
The old glass of red wine idea.
Right. That observation has been seriously challenged. It's now believed to be largely due to the association between moderate alcohol intake and other healthy lifestyle behaviors.
So, healthier people happen to drink moderately, not that the drink made them healthy.
That's the current thinking. This shift has led major organizations like the World Health Organization and World Heart Federation to state that no amount of alcohol consumption is considered safe for overall health. A powerful and clear message.
To effectively address substance use, we really need to understand why women and men might choose to use, because the motivations can be quite different, right? It's not just about the substance itself.
Absolutely. The why is crucial. For example, women are more likely to drink alcohol to improve their mood or psychological state, kind of self-medicating, whereas men tend to drink more in social situations or due to positive emotions.
Different drivers.
Yes. Marketing influences also play a role. Tobacco companies have historically targeted women with products marketed as slim, creating a perception of reduced risk and leveraging concerns about weight gain as a barrier for quitting.
Sneaky.
Very. The stress and trauma pathway is also highly significant. The higher rates of exposure to stress, trauma, mood disorders, anxiety disorders in women, coupled with their differential physiological and neuropsychiatric responses, are recognized as a specific risk pathway for developing alcohol use disorder.
Stress link again.
And perceived stress has also been more strongly associated with nicotine withdrawal symptoms for women, which can significantly affect quitting rates and increase relapse risk.
So, what are the most promising strategies to support women in reducing substance use, given these unique motivations and barriers? How can we offer truly effective help that acknowledges these differences?
Well, more research is certainly needed, but treatment programs that integrate other lifestyle medicine pillars, particularly stress reduction, social connection, show great promise.
A holistic approach.
Exactly. These additive benefits can significantly enhance a woman's ability to reduce risky substances and improve their cardiovascular health outcomes. It's about providing that holistic support, not just addressing the substance use in isolation, but understanding the underlying reasons and building up other protective factors. 2-second quiet pause.
7. Social connection, the invisible health factor, the power of community for women's hearts. Okay, beyond our individual choices, our social world plays an enormous role in our health.
This feels increasingly important.
It absolutely is. The awareness of social connections' significance in cardiovascular disease is rapidly growing. In fact, just last year, 2023, the U.S. Surgeon General released an advisory calling national attention to the importance of social isolation, stating its impact on all-cause mortality is on par with the risks of smoking.
That's a powerful statement. Puts it right up there with tobacco.
It really does. Elevates social connection to a foundational health factor. Now, it's important to distinguish between loneliness and social isolation.
Yes, they're related but different.
Loneliness is that subjective experience, right? Reflecting an individual's dissatisfaction with the frequency and closeness of their social contacts, feeling alone. Social isolation, on the other hand, can be objectively measured by the size and frequency of social contacts, how many people you actually see.
Quantity versus quality, in a way.
Sort of. And both can act independently as cardiovascular risk factors. What's often overlooked is how women's culturally influenced roles as caregivers for newborns, partners, elderly parents can significantly impact their social connection both at home and in the workplace, often leading to increased isolation.
The demands of caregiving can be very isolating. And the impact of loneliness and isolation isn't just direct. It influences cardiovascular risk through all the other lifestyle medicine pillars we've discussed.
Oh, so?
Individuals who are socially isolated often have increased levels of chronic stress, they experience poorer sleep outcomes, tend to have less nutritious diets, and show higher rates of substance abuse.
It all connects.
It all connects. While much of the impact of social isolation and loneliness on cardiovascular disease could be explained by these correlations with other lifestyle factors, the key finding is that those experiencing social isolation and loneliness still have an elevated risk of cardiovascular disease, even after adjusting for lifestyle.
So it's an independent risk factor.
Exactly. This elevated risk, interestingly, did not differ by patient's reported gender. This means social connection is an independent and vital component of heart health, regardless of other healthy behaviors you might be practicing.
Are there any distinct trends that emerge when we look at social connections, specifically for women's cardiovascular outcomes? Does gender play a different role here, for instance, in how loneliness affects women versus men? It seems like it might.
Yes, this is where the picture becomes very interesting and highlights some specific gender differences. One large study examining the impact of social isolation and loneliness on the risk of atherosclerotic cardiovascular disease found that social isolation The objective measure was a significant risk factor affecting both sexes equally.
Okay, isolation affects both.
However, perceived loneliness, that subjective feeling of being alone, was found to be a risk factor only for men.
Only for men. That's surprising.
It is a crucial distinction. It suggests that the subjective feeling of loneliness might affect men's hearts more directly, while objective isolation affects both sexes. Social isolation also varies over the lifetime and is strongly influenced by gender roles in work and home. When researchers accounted for these differences, the sex impact of social isolation on cardiovascular risk was no longer evident.
Meaning the roles explain the difference.
It implies that addressing the underlying gender-based factors of isolation can mitigate its cardiovascular effects. A large review of studies looking at coronary heart disease and stroke showed that a lack of social connection or social relationships was associated with a significant increase in both incident coronary heart disease and stroke risk, but this particular analysis did not identify any sex or gender differences in these risks. So it suggests the specific type of social disconnection, objective isolation versus subjective loneliness, can have different implications depending on gender. It's complicated.
Given these complexities, what interventions have proven effective, especially for women, to foster better social connection and, in turn, better heart health? What really works on the ground?
We have some powerful examples. The Stockholm Women's Intervention Trial for Coronary Heart Disease, SWIT-CHD, demonstrated a significant impact of a regular all-female support group for women who had experienced a heart attack or stent placement compared to usual care.
Women supporting women.
Exactly. Remarkably, no deaths were seen in the intervention group for the first 2 years, and there was an ongoing benefit to all-cause mortality that was greatest after 5 years.
Incredible results.
Highlights the profound power of targeted gender-specific support. Key barriers for women include their frequent isolation from the workplace when serving as caregivers. Also, cultural norms around physical activity can sometimes lead women to avoid certain activities that could foster social connection.
Like maybe feeling uncomfortable in a mixed gym setting.
Could be. However, promising solutions exist. The American Heart Association states that physical activity interventions show the most promise for addressing social isolation in older adults. Improving access to safe, acceptable exercise groups that appeal to women can serve a dual purpose, decreasing social isolation while also ameliorating other risk factors.
Kill two birds with one stone.
Precisely. The Scandinavian model of dual earner and dual childcare for new parents has been shown to increase socialization for women after childbirth. This provides a clear blueprint for how broader societal structures can support women in returning to socially connected, healthy lives across all ages. Policy matters. 2-second quiet pause.
8. Discussion. Integrating knowledge for action. A comprehensive vision for women's heart health. Okay, so what we've deeply explored today really boils down to this. Assessing and addressing lifestyle factors, as outlined in Life's Essential 8 and the 6 pillars of lifestyle medicine, isn't just a good idea. It has a foundational role in both primary prevention, stopping disease before it starts, and secondary prevention, managing it once it's there, of cardiovascular disease.
It's core to heart health.
It's about improving cholesterol, blood pressure, blood sugar regulation, and profoundly supporting overall cardiovascular health.
And we have powerful evidence for this. A massive study, the Million Vet Study, showed the additive effects of consistently living a healthy lifestyle. Adherence to guidelines on physical activity, a whole food plant-predominant nutrition pattern, restorative sleep, stress management, social connections, avoidance of risky substances. It resulted in significantly lower overall mortality.
Even after adjusting for other factors.
Even after adjusting for social determinants of health like income or education, this highlights the cumulative power of these pillars working together. And our deep dive today has revealed that for women, there are distinct biological sex and social gender differences across all these pillars. These include differences in levels of engagement with recommended guidelines, unique motivations and barriers to implementation, specific impacts on cardiac risk factors and physiology, and complex interactions among the LM pillars that differentially influence cardiovascular outcomes. This unique landscape truly demands a tailored approach to women's heart health.
This understanding really empowers healthcare professionals then, doesn't it? To offer more personalized, effective care. It transforms that one-size-fits-all approach into something truly impactful for each individual woman.
Exactly. For primary care practitioners, improved awareness of those early predictors of higher lifetime cardiovascular risk for females, PCOS, HTP, timing of menopause, severe hot flashes, provides critical windows of opportunity.
Those key moments.
Yes, crucial moments to focus on lifestyle medicine, approaches that align with a woman's existing goals. whether it's supporting fertility, having a healthy pregnancy, managing menopausal symptoms, all while simultaneously improving cardiovascular health. A recent presidential advisory from the AHA and ACOG explicitly called for all well woman visits, including the postpartum follow-up visit, should be considered an opportunity to focus on lifestyle choices that optimize cardiac health.
Making it standard practice.
That's the goal. Early referral to preventive cardiology may also be indicated for higher-risk women for additional screening, monitoring, medication management. For cardiologists, that awareness that women often engage in lower levels of physical activity despite potentially seeking more benefits from it than men, well, that highlights the value of using physical activity vital signs.
Asking about exercise, like you ask about blood pressure.
Precisely. Regularly inquiring about minutes of moderate intensity activity and strength training. This can lead to targeted referrals to physical therapists, fitness professionals, gym memberships, ensuring women aren't missing out on those amplified benefits. For nutrition, recognizing that women's nutritional needs vary with hormonal shifts and their motivations and barriers differ from men, like wanting to support a healthy baby, alleviate hot flashes, or overcome income and food access issues, can lead to appropriate referrals. Dietitians, behavioral therapists, social workers. Tailored support acknowledges the full context of a woman's life. For sleep specialists, inquiring about sleep quality and quantity, recognizing the different prevalence and unique ways sleep disorders like RLS and sleep-disordered breathing present in women, often exacerbated by caregiving roles. That can lead to effective referrals. Helps uncover and address those hidden sleep challenges. For stress management, being aware of the higher rates of stress and its greater impact on cardiovascular outcomes for women means that simply asking about stress levels during clinic visits can open a vital discussion. Maybe about stress reduction techniques like deep breathing or meditation, or lead to referrals to board-certified LM clinicians or licensed therapists. And finally, for social connection, recognizing the combined benefits of social connection and physical activity in reducing stress perception for women can encourage physicians to inquire about social supports. Actively encourage women to work out with friends. This counseling could potentially also help reduce alcohol and tobacco use, creating a ripple effect of positive health outcomes. This knowledge isn't just for individual practitioners either. It really calls for broader systemic changes. There's a strong call, notably from experts like Dr. Galati, for the expansion of specialized women's heart centers worldwide.
Dedicated centers. Makes sense.
These centers are crucial to address disparities and provide a comprehensive lifespan approach to cardiovascular care for women. Integrating an interdisciplinary lifestyle medicine team at these centers, dietitians, exercise physiologists, behavioral therapists, social workers, coaches who truly understand women's motivations and barriers, can significantly increase the percentage of women meeting national guidelines for physical activity, strength training, whole food plant-based diet.
Building the right support system.
Exactly. Providing opportunities for regular group exercise shows immense promise for addressing social isolation. A study analyzing data from over 50,000 participants found regular physical activity reduced stress-related brain signaling, leading to a 23% lower risk of developing cardiovascular disease.
Exercise calming the brain's stress response.
Seems so. While not segregated by sex gender, those with stress-related conditions like depression, which is more prevalent in women, derive the most benefit. Suggests exercise can be particularly beneficial for women in this regard. Referring high-risk women to cardiac rehab programs, utilizing community-based exercise programs for lower-risk women can provide added benefits, improving stress symptoms, mood, social support, in addition to increasing adherence to physical activity guidelines. Our sources even propose concrete tools to facilitate these conversations in clinics. First, a proposed 6-question assessment tool, we can link to that. A simple set of questions for clinicians to kick off discussions about lifestyle medicine.
Like what?
Covers key areas like, do you get 150, 300 minutes of moderate or 75, 350 minutes of vigorous aerobic TA a week? Strength train twice a week? Or do you sleep 7-9 hours each night? Wake up well rested? Simple starting points. Second, a proposed lifestyle medicine prescription tool. A checklist for lifestyle modifications, tailored to individual goals, current lifestyle, readiness, perceived ability to change. Examples: I will walk briskly for minutes 5 times this week. Or, I will eat servings of fruits and servings of vegetables each day this week.
Making it concrete and actionable.
Exactly. These practical tools help bridge the gap between knowledge and action, making it easier for both patients and providers to engage with these vital health changes.
So what's the ultimate goal here? Where are we heading with this comprehensive vision for women's heart health? What's the big picture?
Well, While more longitudinal research is certainly needed, the clear message is that earlier implementation of lifestyle medicine, meticulously aligned with women's symptoms, preferences, goals, and crucially, with support for addressing barriers and access, has the profound potential to improve cardiovascular health and prevent or reduce future cardiovascular events.
Moving beyond just giving advice.
Exactly. Moving beyond mere education to actively incorporating factors that enhance motivation and adherence. A deeper understanding of these sex and gender differences regarding the six pillars empowers healthcare professionals to prioritize primary prevention of CVD for women and to support women with existing CVD in achieving their treatment goals, preventing further events, and ultimately significantly improving their quality of life. It's really about a holistic, personalized revolution for women's heart health.
Outro. Okay, that was an incredibly enlightening deep dive. So much to think about. What are our top 3 takeaways for you, our listener, to carry forward from all this?
Okay, top 3 first. Remember that women's heart health is uniquely influenced by that complex interplay of biological sex and social gender factors.
Mm.
General health advice often isn't enough. A tailored, nuanced approach to lifestyle medicine is essential to truly protect your heart.
Personalization is key.
Second, pivotal life stages, particularly reproductive years and menopause, offer crucial windows of opportunity for proactive lifestyle interventions. Recognizing conditions like PCOS, HTP, hot flashes as early heart risk predictors can guide earlier and more effective prevention
I'll
strategies.
be alert during those transitions.
Exactly. And third, seemingly softer lifestyle factors like stress management, quality sleep, strong social connections disproportionately impact women's cardiovascular risk. Addressing these, alongside diet and physical activity, where women often gain even greater benefits, creates a truly powerful and personalized pathway to a healthier heart.
Lifting it back to a final positive example. Elena, late 30s, family history of heart disease, but always felt her concerns were kind of brushed aside.
Happens too often.
Yeah, after learning about the specific impact of chronic stress and poor sleep on women's hearts, she sought a healthcare provider who used the type of assessment tool we discussed today.
Proactive. Good for her.
This led to a referral to a behavioral therapist for stress management and a dietitian who helped her incorporate more plant-based foods, understanding her cultural preferences too. Within a year, her stress markers decreased, her sleep improved dramatically, her overall cardiovascular risk profile looked much healthier. Elena felt empowered, knowing her choices were specifically targeting her unique risk factors.
Elena's story powerfully illustrates how the integration of informed, personalized lifestyle changes, guided by a healthcare team attuned to women's unique needs and motivations, can lead to profound and lasting improvements in heart health. It underscores the importance of both individual agency and a supportive healthcare system that understands and responds to these specific needs. It's really a testament to the idea that knowledge, when applied thoughtfully and personally, can truly change lives.
This deep dive has really shown us that women's heart health is not just about individual choices, is it? It's also about societal support, awareness, and systemic change.
It takes a village, in a way.
It really does. So as we wrap up, I leave you with this thought. How can we, as a community, better champion and integrate these tailored lifestyle medicine principles to truly transform the landscape of cardiovascular health for all women, ensuring that every heart is understood, protected, and empowered? MCQ answers and explanations. MCQ unanswered. D. Optimal cholesterol levels. Explanation. Optimal cholesterol was part of the original Life's Simple 7. The big additions for Life's Essential 8 in 2022 were sleep, psychological health well-being, and acknowledging social determinants, plus refining the measurements for the others. MCQ 2 answer. C. Biological variables like anatomy, physiology, and hormones. Explanation. Remember, sex refers to the biological aspects, while gender covers the social and cultural dimensions. MCQ 3 answer. B. In women with lower socioeconomic status. Explanation. The source specifically pointed out that the negative link between stress and diet was stronger for women facing socioeconomic challenges, highlighting that vulnerability. MCQ 4 answer. C. The highest quartile of fiber intake was associated with a significantly reduced risk of preeclampsia. Explanation.
More fiber, particularly over 21 grams a day, showed a strong protective effect against preeclampsia in pregnant women. MCQ 5 answer C, 60%. Explanation. Physical activity's known effects on risk factors only explain about 60% of its heart benefit in women, suggesting other powerful, perhaps less understood, mechanisms are at play. MCQ 6 answer. C. Women derive almost double the benefit. Explanation. For the same amount of strength training, like 2-3 sessions a week, women saw nearly twice the reduction in mortality risk compared to men. A huge difference. MCQ 7 answer. C. Restless leg syndrome, RLS. Explanation. RLS is more common in women overall, and its prevalence jumps significantly during pregnancy, especially later on. MCQ 8 answer. C. Increased frequency and severity of vasomotor symptoms, VMS, or hot flashes. Explanation. Hot flashes, along with hormonal shifts like lower estrogen and higher FSH, are strongly linked to poorer sleep during the menopause transition. MCQ 9 answer. C. More than 2 times higher risk. Explanation. The InterHeart study showed high stress more than doubled the risk of a heart attack, a really significant finding across diverse populations. MCQ 10 answer.
C. Takotsubo syndrome, broken heart syndrome. Explanation. Takotsubo syndrome overwhelmingly affects postmenopausal women, 80–90% of cases, and the loss of estrogen's protective effects against stress hormones is thought to be a key factor.